Radhe Radhe and Namaste. Welcome to our JKYog Health webinar series. Today we have Dr. Manish Assar with us, and he'll be talking about syncope, and that is what the doctor wants to know and the symptoms and the causes of that. Thank you very much, Doctor, for joining us today from your busy schedule. And we also have Dr. Kandalwalji with us, and he's the one who is helping us coordinate the health webinars. So let me introduce Dr. Asarji. He's a certified cardiac electrophysiologist at Baylor Heart Vascular Hospital in Dallas, Texas. He specializes in taking care of patients that have heart rhythm abnormalities and heart rhythms that are too low and too fast and irregular that frequently require invasive procedures such as pacemakers and catheter ablation for treatment. He's a fellow of American College of Cardiology and the Rhythm Society. He graduated from University of Texas at Austin with a BS in biomedical engineering science, and he went to medical school at University of California, San Francisco, where he obtained his MD and received a gold-headed cane award, the highest award given by faculty and classmates to a graduate. He subsequently did his internal medicine residency at University of Texas Southwestern Medical Center and fellowships in general cardiology and cardiac electrophysiology at Duke University. The following year, he spent in London, Ontario, in Canada, where he did his an extra year of cardiac electrophysiology training. And later on, he been to Baylor Hospital in Dallas since 2002. He's been there. And he's been a program director for a electrophysiology and fellowship since 2008. He's also an associate professor medicine at Texas A&M College of Medicine. He spends his time caring for patients, of course, teaching fellows and medical students, and has been involved in clinical research and publishing and reviewing scientific papers. So let's go ahead without wasting much time because I've taken a lot of time. Okay, so over to you, Dr. Manish Asarji.
Okay, thank you very much. Good evening and good morning, depending on where you are in the world. I want to thank Beena and Rajan and Dr. Kandawal for arranging this session. And I hope you find it very informative. I'd like to make it very informal, and we'll have plenty of time for some questions that you can answer. So I'm going to share my slides with you here, and then we'll get started. Okay, can everyone see that okay, Beena?
Yeah, yes, we can see.
Perfect. Okay, good. So, you know, the word syncope, you might have not ever heard what this means, but it basically means a loss of consciousness. And what I want to talk about today is the patients that have loss of consciousness. And it's very common. About 40% of the population at some point in their life lose consciousness. Many of you listening know of someone that's lost consciousness or have lost consciousness yourself, and you probably realize that this can happen to young people, teenagers, up to people that are in their 80s or 90s. And so it's a very common problem. So what I want to give you is an idea of what things you should keep in mind when this happens to you, because the doctor is going to want to know the answers to some questions. And so this way, by being educated about this, you and your significant others and family members can kind of keep in mind what are the important things that they have to sort of register if someone loses consciousness. So the most important thing that goes through my mind when a patient comes to see me who has syncope or has lost consciousness is that it's my responsibility to figure out that is this a potentially life-threatening problem or not. I'm trained in cardiology, general cardiology, but I specialize in the electrical system of heart rhythm abnormalities. And as I'll show you in subsequent slides, when the heart rhythm gets too fast or gets too slow or gets too irregular, then the blood pressure can drop, and that's what causes lack of blood flow to the brain and loss of consciousness. So this can be potentially a benign problem, something that people live with all through their lives. I have patients that have had passing out spells since they were teenagers, and they have clusters of spells that start in their teenage years, and they might go 2 or 3 years and not have any problems at all. And then again, when they're in their mid-20s, have some more problems. And this can continue throughout all of their lives. And so what I want to stress to you is that the questions that are asked by your physician and the answers you give them are very important. That's how we make a lot of decisions in determining whether other additional testing needs to take place, or whether we think this is a life-threatening problem, or whether this is a benign problem. And so, but it is incumbent upon us, it's our responsibility as physicians to try to, what we call in a medical term, risk stratify people, meaning put them in a high risk category or a low risk category of whether this is a dangerous problem or not. There are some rhythms that are, there are sometimes when people have loss of consciousness where they pass out and then they wake up 10 seconds later, 15 seconds later, that are very worrisome to us, especially when people have, they're older, they have no warning at all. If it happens when they're sitting down, those are all things that I'll go over a little bit later, but those are all sort of things that they put triggers in our mind to say, hey, you know, I think this is potentially a life-threatening problem and I have to take this, have this evaluation done more quickly. So when we talk about loss of consciousness, there are two basic organs that we're concerned about, okay? One is the heart, which obviously involves me, but then the other one is the brain. And frequently, patients get ping pong between heart doctors and brain doctors, and they're called neurologists. And we sometimes have to work in concert to figure out exactly what causes the loss of consciousness. Is it from the heart or is it from the brain? Now, it's almost invariably always from the heart. It's rare that some things in the brain can cause loss of consciousness, such as seizure activity is probably the most common thing. But in that case, you know, if you have a witness, they can usually tell you that there was some convulsive activity. There was shaking of the arms or the legs, and so. The things mostly that cause loss of consciousness that meet the definition of syncope, which we'll define here in the next slide, are coming from the heart. Okay, but those are the two organs that we have to worry about, the heart and the brain. So if we define syncope, we already told you that it's loss of consciousness. Okay, so someone has to lose consciousness. We're not talking about someone getting dizzy or lightheaded. We're talking about someone that loses consciousness, meaning if you go over and you try to shake them, they don't wake up, okay? And it's usually sudden and it's brief, all right? And so it's not like if someone gives me a history that I've been feeling dizzy all day and this has been going on for a week and then I got, you know, that's not syncope. Syncope it defines as loss of consciousness is sudden. So within a matter of a minute or two, people might be feeling fine 1 minute and the next minute they end up falling to the ground, okay? And the duration of the loss of consciousness is brief, usually less than 5 minutes, okay? Anything more than 5 minutes, we have to think that it's coming from the brain, but it's usually, if it's coming from the heart, it's usually less than 5 minutes, because if it's more than 5 minutes and it's coming from the heart, then that's potentially people don't live, they usually die. And so the duration is very important. So I'm trying to give you some idea of some of the things that physicians are going to ask you, or your loved one who has witnessed this. They're going to ask you, how long was it? Was it sudden? The next thing they're going to ask you is that, was it associated with a loss of postural tone? So, you know, postural tone means, posture means standing upright, right? What are you doing? So if someone's standing and they lose consciousness, they hit the ground, okay? A lot of times people have injuries from loss of consciousness, from passing out. They either, you know, crack their hip, or sometimes they crack their skull, or they get a head bleed. And we know that if someone loses consciousness and they have any kind of facial type of trauma, that they've had very little warning, because our reflex system is usually very good. Meaning, you know, if you trip, for instance, you automatically, the reflexes are such that your arms usually go straight out and they break the fall so that your head doesn't get damaged. But if people are passing out and they're having trauma to their facial reasons, then that's really a sign that there's something serious going on. And recovery is spontaneous and it's prompt, meaning the episode happens quickly. People hit the ground, or if they're sitting in a chair, they slump over. And then recovery is spontaneous and it's prompt, meaning the duration is really short, and there's nothing that you have to do, that the bystander has to do, to have the patient come back to consciousness. They come back to consciousness automatically. So those are characteristics of syncope, is that you have to lose consciousness, it's sudden and brief, you have to basically fall over, and the recovery is spontaneous. And the underlying mechanism, what's really happening when someone loses consciousness, when someone has syncope, what's really happening is that there's lack of blood flow to the brain from a drop in blood pressure, okay? And so the brain has to be constantly fed by blood, which carries oxygen, in order to maintain consciousness. And when there's a lack of blood flow to the brain, then people lose consciousness. And the most common reason for lack of blood flow is a drop in blood pressure, right? Our blood pressure, we know, typically runs 120, 130 over 80 or so. That's normal blood pressure. You know, when you get down to the 60 millimeters of mercury range, where the top number is 60, then you end up having problems maintaining consciousness. And so the different reasons people's blood pressure can drop is either the pump, the heart is the pump, or there's not enough fluid, meaning there's not enough blood, or the container is not working, or the blood vessels. Okay, so if we just look at these separately, if someone has a weak heart, or someone has a heart whose valve is not opening properly and the blood cannot get from the heart to the brain because there's a valve in the way that's very sticky, then people can lose consciousness that way. If someone is dehydrated, okay, if they've been out in the summer heat, 102 degrees, and they've not had anything to drink, and they've have a lot of sweat, they perspire a lot, you lose a lot of fluid that way. So it's not actual blood they lose, but they lose just saline type of fluid. Or if someone has a GI bleed, if someone has, let's say, a bleed out of their, they have a cancer and they bleed from their bottom, their buttocks, and they lose a lot of blood, then all of a sudden the fluid level is very low and the blood pressure is going to drop. And if the blood pressure drops again, then the brain does not get to see that blood, and people can pass out that way. And lastly, the blood vessels. The blood vessels have to maintain a certain amount of rigidity in order to maintain the blood pressure. And so if the blood vessels, if they dilate, if they get bigger, then the blood pressure can drop that way because there's more of a volume and the blood tends to go down towards gravity if someone's standing up and it doesn't get to the brain. So reasons for this is, if someone gets an infection, a bad infection can cause the blood vessels to dilate. Some people who have bad allergic reactions can cause blood pressure to dilate, and that can cause a drop in blood pressure. So the main thing is that when someone passes out from syncope, the reason is because there's not enough blood flow that's going to the brain, and that's because of a drop in blood pressure, okay? So if you're able to take someone's blood pressure right when they pass out, then you will see that their blood pressure is much lower than it usually is when they're awake. So what is the scope of the problem? Well, on this chart, you could see that you have the age groups here, starting on the left-hand side, 20 to 29, all the way up to senior citizens above 80, and then you see that the rate of syncope is on the axis here, the y-axis here. And what this shows you, just if you look at the chart overall, this shows you that as people get older, that there's an exponential rise in people losing consciousness from syncope, okay? It also shows you that there is, even at young ages, like I said, I see patients that are in their teenagers up to 80 who have loss of consciousness. Even at young ages, people lose consciousness, but as people get older, the rate is much higher with loss of consciousness. And you can see that men here in the white compared to women here in the black, they're almost equally affected throughout all age groups, okay? And as people get older, there's several reasons why they tend to pass out more. One is they don't have the usual reflexes, where when a young person stands up, their blood pressure drops a little bit, but then their heart compensates by beating a little bit faster. Older people don't have that reflex as well. And so many of you listening might experience that when you get up first thing out of bed in the morning and you put your legs over your bed and you try to get up, or you're getting up in the middle of the night, that's when you feel that you're going to pass out. And that's because when people stand up, their blood pressure drops, and the older people don't have the reflexes to where they can maintain their blood pressure because the nervous system is a little bit abnormal. The other reason older people can pass out more than younger people is that they're on several medications that are used for other things, such as, for instance, treating the prostate, or treating a heart condition from a blockage, or treating kidney disease, etc. These medications not only can cause, the side effects of these medications can cause the blood pressure to drop and cause loss of consciousness that way, okay? So once again, if you go see your physician because of a loss of consciousness spell, make sure you know what your medications are. They're going to ask you, what are your medications? Have you had any recently new medications? Have you had any changes in doses of medications? Those are all important questions that they're going to ask you, and you should have the answers for, okay? The other reason older people have loss of consciousness is because they start developing heart disease. This is when people end up getting diseases of the valve, or diseases of the coronary arteries, the blood vessels that feed the heart. They have heart attacks, and they have abnormalities in their electrical conduction system. And so as the heart gets older, it starts getting a disease with different things. And because older people tend to have those diseases, they're more likely to have loss of consciousness. And as I mentioned at the outset, about 40% of you, so 4 out of 10 people who are listening to this talk are going to experience or have experienced at least one syncopal or loss of consciousness or passing out spell in their lifetime. Now, 95% of syncope is from problems with the cardiovascular system, and some of these are dangerous. And like I said, there are typically two causes of syncope. One is the brain, and one is the heart. And most of the time, we are dealing with the cardiovascular system, the heart and its blood vessel system. And like I said, some of these are benign, meaning they're not dangerous, but some of these are dangerous. And the way we as physicians try to figure out whether something's dangerous or not, we rely on the history. We rely on what you tell us and what any kind of witness that has seen the episode tells us. And then we do a physical exam. And then we run some basic tests, including an EKG and most likely an ultrasound of the heart or an echocardiogram. And so with those three things, the history, talking to you, examining you, and doing some testing, we can have a good idea of whether we're dealing with something dangerous or not. Give it to me straight, doc. How long do I have to ignore your advice? Okay. So this is a complicated slide, and I'm not going to go over this in detail. I just want to share with you that this is what goes through our mind when we're talking to you. So these are the different reasons for transient loss of consciousness, for brief episodes of passing out or of syncope. Okay, these are the different reasons. And so what we try to do when we're asking you these questions and we're evaluating you by physical exam is we're trying to figure out which one of these bins or boxes do we put you in. Do you have neurally mediated syncope, orthostatic syncope, a rhythm problem, structural heart problem like a valve, or is it non-syncopal? Non-syncopal means you got a low sugar, or it's psychiatric, or it's a seizure, okay? But what I want to stress to you is that, as you can see in all of these categories, there are 5 or 6 different things that can cause loss of consciousness. So what we have to do as physicians is we have to figure out in which category is my patient going in. Are they going in the benign category, a neurally mediated syncope, the simple faint, orthostatic, meaning their blood pressure drops when they stand up, or is it a rhythm problem? So, but by asking you all these questions and doing all this exam, we're trying to figure out what diagnosis you have. And this is what's going through our mind, is we're thinking of these 5 categories and which one applies to you. So we start that by doing the initial evaluation. That's a very detailed history, okay? So this is why, we ask a lot of questions. And the problem is that you might not be able to give us the answers to those questions because you lost consciousness. And so a lot of times it's very good to bring a witness with you, someone who actually saw the episode. And if you're lucky enough to have someone like that, take them to the office with you, okay? Because that'll help a lot. Most of the diagnosis is from history, is from talking to people and trying to find out what exactly happened. Now, what questions do we ask you that are important? Well, we're going to ask you, what are the circumstances just prior to the attack? Okay, because what happened right before you passed out? What position were you in? Were you sitting? Were you standing? Were you lying down? That gives us a lot of information in what is a possible diagnosis and what's not a possible diagnosis. Okay, so if you said, well, I passed out and I was lying in bed, then we know that it's not the orthostatic. It's not because you stood up. It's not because of drugs typically. It gives us a lot of information as to the position. So keep that in mind. What position were you in when it happened? What was your activity? Passing out when someone is running or they're biking or doing something very strenuous like that, and they pass out without any warning, that's potentially a life-threatening problem. Okay, so if I have a marathon runner who's at mile 13 and he passes out with no warning, I'm very worried about him. He's going to have a very detailed evaluation to make sure he has nothing life-threatening. Okay, what was the situation? Some of you might have encountered that you pass out when you see insect on the floor in the corner, or when you get your blood drawn. It's very common when someone gets their blood drawn, they might get nauseated or sweaty and they pass out. So that we know, if you give us that history, we know that that's a benign cause, that we don't have to worry about that. That's not a dangerous cause. What are predisposing factors? Meaning, what in your history is important? Meaning, do you have diabetes? Do you have heart disease? Do you have other things? Precipitating events, kind of the same thing as a situation. Okay, so we're going to ask you a lot of things about circumstances just prior to the passing out. And then we're going to ask you the onset of the attack. When it starts, did you have a prodrome? A prodrome is meaning it's a feeling that people have before they're going to pass out. They say, I was doing okay. I was standing there for an hour, and then I got tunnel vision. My hearing started decreasing. I started getting sweaty. I got nauseated. And these are things that occur right before the passing out spell. Um, with seizures, people have they have rotation of their head to one side or the other. Palpitations, that means that they feel their heart beating fast right before they pass out, and that's, you know, worrisome. If someone's heart starts beating extremely fast when they're sitting down and then they lose consciousness, then it's most likely a heart rhythm problem. What about the skin color? A lot of times people, they have skin color, their lips turn blue and their skin turns white. And that's what happens when people blood pressure drops significantly, okay? The duration of the attack, like we talked about, is important. Anything more than 5 minutes of loss of consciousness episode points more towards the brain than the heart. Obviously, if someone sees convulsions, meaning shaking of the arms or legs or seizure activity, that points more towards the brain. If someone loses their control of their bowel or bladder, if they pee in their pants or they poo in their pants, and then that is suggestive that they might end up having some kind of seizure activity, or they could end up having the simple faint. Okay, tongue biting. Someone passes out and then they wake up and they find out they've bitten their tongue. That's very suggestive that that loss of consciousness episode is coming from the brain. It's a seizure. The end of the attack, was there confusion that persisted? Patients that have seizures, they're often confused for the next 10, 15 minutes. And so that'd be helpful to know. Is there nausea and vomiting? That's suggestive of a simple faint. Muscle ache, that occurs when people have a seizure activity or they have a simple faint. And the background, okay, the number of episodes. If patient comes to me and said, hey, you know, I've passed out, and I ask them how many times they passed out, and they say, well, I've passed out, you know, 20 times in the past year, then I worry a little bit less about them, because that's usually a benign cause. And the higher the number of episodes of passing out spells, that says it's not as dangerous. Okay, ironically, you might think about it differently, but that's what it tells us. The past history, the heart history, the brain history, neurology, diabetic is important. The other very important thing is family history of passing out or loss of consciousness. Has anyone had syncope, or has anyone died at early age of sudden death? Okay, because there are some genetic causes of loss of consciousness that are potentially life-threatening. So we always ask about the family history. And then, as I mentioned, particularly for older patients, bring your medications with you. And we'd want to know whether any new medications have been started, or have there been any recent changes in the doses of medications, okay? So that was history. This is what we get from talking with you, or talking with a witness who saw the episode, okay? And then we go to the physical exam, and we have a relatively focused physical exam. We want to check your blood pressure, and we want to check your blood pressure not just while sitting in a chair, but we want to do what we call orthostatic blood pressures, meaning against gravity. So we want to check a blood pressure and a pulse when you're laying down on the table. And then we want to check your blood pressure 5 minutes later when you're sitting. And then we want to check your blood pressure 5 minutes later and your pulse when you're standing. Okay, and you know what's normal to have is about a 20 millimeter drop in blood pressure upon standing. So when you're lying down, your blood pressure might be 130 as a top number. When you stand up, it might go down to 110. But if your blood pressure goes down to 70 from 130, that's abnormal. Okay, so we want to take blood pressure and pulses in different positions to see whether you have what we call orthostatic hypotension, which is low blood pressure. The other exam that we do carefully is a cardiac exam, obviously. And we do this by feeling your pulses in your neck, in your wrists, in your legs. And then we also auscultate or listen to your heart sounds. We want to find out if you have any murmurs, which signifies that there might be some valves that are not opening properly. There might be blocked up, and the blood might be not getting through those valves, and thus might not be getting to the brain and being a problem, causing your loss of consciousness spell. And lastly, when we concentrate on the brain or the neurologic system, okay, we want to look at the nerves in your head, what we call the cranial nerves. Do that type of testing. Test for motor strength in your arms and your legs by having you push and pull with our arms. We check sensation. We touch you with different things on your skin to find out whether or not you can feel this or that. And then we might have you ambulate or walk to see how your gait is, whether you're having any trouble. And then we test your sort of your what we call vestibular system, where you have you close your eyes, or we have you touch your nose and touch your finger and go back and forth to try to get an idea whether or not how well your coordination is. The next thing we do after the physical exam is almost everyone gets an electrocardiogram, an EKG or an ECG, and this is a test, as you know, that they put the sticky patches on you, and they run the paper, and they see, whether your heart rate is what your heart rate is, and whether you have a normal rhythm or whether you have an abnormal rhythm. And then lastly, almost everyone gets an ultrasound of the heart or an echocardiogram. And this is a non-invasive test. There's no needles or anything involved. We just have a wand or a probe, and we put some jelly on it, and then we start taking pictures of your heart from the outside of your chest. And this gives us a good idea of whether or not you have any valvular problems, how thick your muscle is, whether your muscle is strong or not. It gives us a great idea of the anatomy of the heart, and also whether the valves are functioning properly, is the blood flowing properly through the valves. And so I'd say these are the two most important tests that we do for the initial evaluation for someone who has loss of consciousness. Because if both of these are normal, if the EKG is normal and the echocardiogram is normal, then that almost excludes any kind of life-threatening problem, okay? And so these are sort of basic tests that we want to do. There, as I'll show you, there's several other tests we can do afterwards, but it really depends on their history, what you tell us, what we find on the physical exam, what we find on the EKG and the echo as to what other tests, if any, are required. Now, you might be asking, well, do I need to be admitted to the hospital if I lose consciousness? Okay, so the different things that we think about, obviously, if we're worried about you, if we think you have a potentially dangerous problem, then yes, you do need to be admitted. Now, what might be some signs or symptoms that are potentially dangerous? Okay, so if you tell us that you lost consciousness while lying down, or while you were exerting yourself, while you're running or biking or something like that, we're worried about you. And just with you telling us that, we might admit you to the hospital to expedite the workup, to make a more rapid diagnosis for you, okay? If you tell us that you lost consciousness and right before that you had rapid heartbeat sensations in your chest, that also concerns us for potentially life-threatening fast heart rhythm, and that would almost buy you a ticket to being admitted to the hospital. A family history of sudden death. If you say, I've had a brother or a sister who, was 40 years old and she died all of a sudden, or they died in their sleep, and someone went to find them and they wouldn't wake up, and then you yourself had loss of consciousness, we're worried about that. We would admit you to the hospital. If you have significant abnormalities on your EKG, okay, once we take the EKG or ECG on you and your heart tracing has significant abnormalities, we would admit you. Or if we talk to you and we suspect and examine you and we suspect you have muscle or valve disease, or you're having active chest pain or shortness of breath, that would buy you a ticket to the hospital. Okay, so these are sort of the things that we're extremely concerned about if you tell us, and you would be admitted to the hospital to have a faster kind of evaluation and diagnosis. So on the flip side is, obviously a lot of people don't have these things, but they still have had a passing out spell. So a lot of people we evaluate as outpatients. Okay, if people that we don't think have a life-threatening problem, we evaluate as outpatients, and we do that by might be giving you a monitor to go home with and that you wear. And if you have another spell of loss of consciousness, then we can see what the EKG shows. And so whether we do an inpatient or an outpatient evaluation really depends on whether we think you have a dangerous problem or not dangerous problem. If it's not dangerous, then we would evaluate you as at home as an outpatient. So that's the initial evaluation, is the history, the physical, and then the EKG and the echo. Now there are a number of secondary evaluations, okay? So depending on what the initial evaluation is, we can, if you give us a story that when you start walking, that you got chest pain and tightness, which went to the neck, which went down the arm, they gave you nausea, you were sweaty, then we're concerned that you might have a blockage in the heart. And we'd want to get an exercise treadmill test. A stress test is what this is, to see whether or not you have any blockages in the heart. If you give us the next step, if you have a positive stress test, or you have a very concerning, you give us a very concerning story for a lot of chest pressure, and you're diabetic, and you have high blood pressure, you have high cholesterol, we might take you and do a procedure on you called a cardiac catheterization, an angiogram. And this is a test where we go through the blood vessels in your wrist or down by in your leg, and we take a catheter to your heart, and we take pictures to see if we have any blockages in the blood vessels. Sometimes we do a tilt table test. This is particularly for young patients who pass out that are maybe in their teenage years or 20 or 30, and they give a history of, they get sweaty, they get nauseated, and then they passed out multiple times. And sometimes we try to replicate that on the test called a tilt table, where we put them flat on the table and then we tilt it up, and we try to replicate their passing out spell on there. So that's looking for the simple faint. A cardiac MRI or magnetic resonance imaging, okay? If we're worried about if we're worried about how the muscle looks of the heart, we're worried about how the valves look in the heart, then we might get a cardiac MRI to try to figure that out. Or we could send you home with an external rhythm monitor. We give you some patches and some wires and with a little box, and we say, wear this device for a month, except when you take a shower. And if you pass out again, then we can see what the rhythm is at the time you pass out, okay? Now, obviously, if we're going to send you home with a rhythm monitor, we don't want to see a dangerous rhythm on the other side, right? Because if we give you a rhythm monitor and you pass out and you don't wake up, then that's called sudden death. And so we don't want to give rhythm monitors at home to patients that we're worried about. We want to admit them to the hospital, okay? So if you're getting a rhythm monitor, that means the doctor is worried about you, but is not terribly worried about you, okay? There are external rhythm monitors. Some of the rhythm monitors sometimes we place under the skin, and they have a battery for 3 years. And these are for people that have passing out, loss of consciousness, or syncopal spells that are very infrequent. Sometimes someone passes out only twice a year. It always happens 2 or 3 times a year, separated by a number of months. And it's not practical for them to have an external monitor. So we implant a monitor under their skin. And these are very smart devices. You could program these devices to store to say, well, if the patient's heart rhythm gets below 40, I want you to save that. If it gets above 170, I want you to save that. And then you have another kind of bedside monitor that talks to this monitor under your skin, and that information can go directly to our office. Okay, so there are all these different technologies we can use. And a procedure that we do is called an electrophysiology study. This is similar to invasive procedure that we put catheters or small tubes into the bloodstream, and we take those catheters to the heart, and then we pace the heart, and we try to bring out abnormal rhythms, or we take measurements, okay? So as you can see, there are a number of secondary tests we do. Some of them are invasive, that require you to come in and get a procedure done. Others of them are just imaging studies. And which one of these we select really depends on your history that you give us and the physical exam and what the EKG and the echo initially shows. So getting back to this table, remember I tell you, when you give me a history that you pass out, or your witness gives me a history, I've got to put you in one of these five categories, okay? And the way I do that is by talking to you and doing a physical exam and doing different tests. And then we come up with the several kinds of diagnoses. As you can see here, you could probably see there are about 5 diagnoses in each category. So there might be 25, 30 things that can cause loss of consciousness. And we have to try to figure out which one it is. Now, what are the potential treatments? Well, the potential treatments really depends on what the potential cause is, right? And so one thing, if you have the simple faint, meaning if you get an IV put in or a blood draw and you pass out, then we would say, well, try to avoid the trigger, try to avoid the blood draw. Sometimes that's possible, sometimes it's not possible to avoid the trigger. But some people have triggers of prolonged standing. Some people, if they stand for more than 30 minutes, they start getting dizzy and nauseated and sweaty. And so we tell people to recognize what their prodrome is. And that's the next one, I think. Recognize the onset of symptoms and lie down. So if you feel like you're going to pass out, no matter what the cause is, lie down. The reason people pass out is because their blood pressure drops, and the heart, as you know, is below the brain when you're standing up. So you're working against gravity. Now you want gravity to be your friend. If you want gravity to be your friend, you have to get the heart and the blood and the brain at the same level. And the way to get it at the same level is you lie flat on the floor. And sometimes it's embarrassing for patients if they're at a restaurant or at work, if they feel like they're going to pass out. If they try fighting it, they're going to lose, and they're going to pass out and potentially hurt themselves. But we always tell patients, if you feel the symptoms coming on, if you feel like you're going to get dizzy, you feel like you're going to pass out, no matter where you are, just lie down in a safe place. And if you get your brain and your heart at the same level, then your blood pressure, although it might drop, it won't drop to a point where you'll pass out, okay? Increase salt and water intake. So that's a key in especially teenagers, or in people that tend to be outside and they get dehydrated and they get sweaty and they lose a lot of fluid. So we tell them to increase the salt and water intake, okay? Unless someone has high blood pressure, and many of you might have high blood pressure, and you've been told for the past 15, 20 years, don't take salt and don't take water, and that's still true if you have high blood pressure. But if you don't have high blood pressure, and you are passing out frequently, then we might just recommend increased salt and water intake. If we find that you're a patient that has lost consciousness, and right before you lost consciousness, you gave us a history of the chest tightness that went to the arm, that went to the neck, and you got sweaty, then you might end up with a catheterization or an angiogram. And then if we find a blockage, then we might do a balloon angioplasty. We might open up that blockage and put a stent in and restore blood flow to the heart. If you have a lot of blockages, then you might end up with a coronary bypass operation, okay, where it's an open chest procedure. If your heart rate is too slow, we have patients that come in whose heart rate's 20 beats a minute, 30 beats a minute. You know, normal heart rate runs 60, 70, 80 beats a minute, but if it gets too low, then it cannot maintain a blood pressure. And patients sometimes need permanent pacemakers implanted. Now, if someone has a very fast, dangerous rhythm, so people that have weak hearts, that have heart attacks, can have what are called ventricular rhythms. These are abnormal, fast rhythms in the bottom chamber, ventricular tachycardia. These are, you know, when you hear about patients or people that are out on the street and they pass out and they die suddenly, they're usually dying of a dangerous, fast heart rhythm from the bottom chamber. And now we have technology where we can implant a device under the skin with the wire going into the heart. They can watch every heartbeat. Every heartbeat is monitored. And if you get to a point where your heartbeats are going too rapid, and we can program this, we can say if it gets above 180 or 190 beats a minute, it'll apply a shock, just like you see on TV or on the news when someone has a dangerous rhythm, and you have the paramedics go and they give a shock from the outside. Well, this device gives a shock from the inside, and they can convert a dangerous rhythm back to normal rhythm. That's called a cardiac defibrillator. And there's a procedure that we, as heart rhythm specialists, electrophysiologists, we do called catheter ablation, where there might be short circuits in the heart that lead to very rapid heartbeats, 170, 200 beats a minute. And our goal is to find out where the short circuit is in the wiring of the heart. And we can go up there and we can burn the short circuit. And, you know, cure rates with this are sometimes in the 90% range, okay? So again, the point I want to make is that there's several treatments. It really depends on what the diagnosis is. And what the diagnosis is really depends on what you tell us, the questions that we ask you and the answers you give us. And so that allows us to make the appropriate next evaluation, okay? The last thing I want to stress, and this was my wife's idea, she's a family doctor, Paolo's idea, is to learn CPR, cardiopulmonary resuscitation, okay? And now in the COVID times, it's difficult to do it in person, although some places they are offering it, but you can do it online now. American Heart Association, the Red Cross, several other organizations, I'm sure in India and across the world, have online courses. And so while you're online, you have more time on your hands. Learn some basic cardiopulmonary resuscitations, basic CPR. You could save someone's life. And, you know, passing out, we talked about loss of consciousness, and we talked about transient loss of consciousness, meaning people that pass out, they wake back up. But if people pass out and they don't wake up, that's called sudden death, okay? And CPR can save a lot of people. With an educated public, we know that people that, cities that have teach CPR and school districts, etc., they have a higher survival rate if someone has a cardiac arrest on the street somewhere compared to school districts that don't, cities that don't. So I would urge you to try to learn CPR. At your age, good health is pretty much a thing of the past. My advice is find an illness you enjoy. Okay, I'd be happy to answer any questions if we have time.
Oh, yes, we do have time. Okay, let's ask questions. We have question from Megha. She's asking a question that What should we do if someone faints in front of us? Is there anything we can do to help them, or?
Yeah, that's very good. Very good question. Very appropriate question. What you should do first, and this is what I mean about learning about CPR. Okay, so you find out whether they're conscious or not. So you go and you shake them and you call their name and you say, "Hey, are you awake? Are you awake?" And you see whether they're conscious or not. And if they are conscious, and then what you want to do is you want to keep them. If they're not lying down, you want them to be lying. You get someone to help to lie them down on the floor somewhere. Okay. If they're sitting in a chair or something, you want to get someone's help to try to lie them down. And then you want to check for their pulse. Okay, you could check for their pulse in their neck or in their wrist, and you want to get an idea of kind of how fast the pulse is, and so you can try to measure it over 15 seconds. At the same time you're doing all this, you want to yell out if you have someone else in your house. You want them to call 911. Okay, especially if this is a first passing out spell. So you want to get some help. If you know that someone has frequent passing out spells and you already know what the diagnosis is, I think that's less important you do that unless there's some trauma involved or if the patient has chest pain or shortness of breath. And then if someone passes out and you check a pulse and they're back to normal, sometimes a lot of these patients, like I said, they briefly pass out for a minute or two and then they're back to normal and they say, well, I feel just like I felt before. And even if you call paramedics, they don't want to go to the hospital because they feel fine. Then I think what you need to do is to those type of questions that the physician is going to ask you. What was the patient doing? How long was the patient out? And what was the duration of it? Was there any seizure activity? Did they lose any bowel or bladder? Think about those things and maybe take notes, because these are things that are easy to forget. But the more details that you can give us when we ask you these questions, the better we can take care of you.
Okay, thank you. And
Yeah.
they're supposed to be prepared to go with the patient next to, with the to the doctors. Yeah. Okay, thank you.
Yeah.
Now, someone asked, I am 55 years old and I have orthostatic hypotension. How could that be treated?
So orthostatic hypotension, what we need to figure out when someone has that, is there a reversible cause to that? Okay. Sometimes there's a reversible cause. Other times there's not a reversible cause. The reversible cause that we think about, we want to make sure you don't have a Parkinson's type of syndrome. Some neurologic type of abnormalities can be present that cause orthostatic hypotension. Patients that have longstanding diabetes, they end up getting a neuropathy or nerve problems in their legs, and those nerves don't function as well. And the nerves are needed to help the blood vessels clamp down and keep the blood pressure up. So what we need to do for patients like that is to first find out what's the cause of the orthostatic hypotension. For a 55-year-old, it's a little bit young. Most people that have this problem that have no identifiable cause are typically in the 70s or 80s. Then we want to look at your medications. There are a lot of medications that are used for different type of things that can end up causing orthostatic hypotension. But if you go through the whole evaluation and they say, well, we cannot find anything that we can treat that's reversible, there are no medications that can do that can be the cause of your symptoms, then we start with conservative measures, education. Okay, so instead of getting up out of bed quickly, we ask people to hang their legs over the bed for 5 minutes and then stand up and go. Then there are other type of things. If the patient does not have high blood pressure, we ask them to increase the salt intake, increase the fluid intake. Lastly, there are some medications that can be used to increase the blood pressure that we can prescribe. There's some things that are called stockings that we can put, long stockings that we put on the legs all the way up past the knees. that help squeeze the fluid out from the legs up to the heart that can try to maintain blood pressure.
Okay, thank you for that. Someone has asked, what heart rhythm disturbances can cause syncope?
There's several of them. You know, a very slow heart rate can cause syncope. A very fast heart rate can cause syncope. So generally, if heart rates are between 50 and 150, don't cause syncope. But anything more than 150, anything less than 50 can end up causing syncope.
Okay, thank you. All right. Someone has asked, how is cardiac, I might be pronouncing it wrong, arrhythmia causing syncope detected, and is it treatable?
Are you asking about arrhythmia?
Yes, arrhythmia.
Okay, cardiac arrhythmia is basically arrhythmia is heart rhythm.
Okay.
So that's the same kind of question that we had before. So if the heart rhythm is too slow, meaning less than 50, then the patient might need a pacemaker. If the heart rhythm is too fast, above 150, they might need pills, or they might need what we call an ablation procedure, where we can burn a short circuit in there. And so the way it's diagnosed, though, is by one of these monitors, okay, by an EKG, an electrocardiogram, or a monitor that looks at the heart rhythm at home. We can send people on home monitors and try to make a diagnosis that way.
Okay, all right. Now, do structural heart diseases can cause syncope?
Yes, and those are the dangerous type of syncope. Structural heart disease, meaning heart whose anatomy, whose shape is distorted, who is not normal. And reasons that can occur, one of the main reasons is heart attacks. When people have a heart attack, then their heart muscle dies and it becomes weak and it can't pump properly. And so that's a form of structural heart disease. Another form of structural heart disease is valvular disease. If the valve, like I said, does not open very well, it becomes sticky, then blood cannot flow through the valve. That's another type of structural heart disease. So the echocardiogram, the ultrasound of the heart, that's the test that's used to see whether someone has structural heart disease or not. And if the echocardiogram or ultrasound of the heart is abnormal and someone has syncope, we become very worried about them. And that would be a reason to admit someone to the hospital.
And it might need a treatment right away, or?
Yeah.
Okay. Someone has asked role of ecoptic beats.
Ectopic beats. Yeah, ectopic beats.
Ectopic.
So what are the electrical system of the heart is really incredible because it has a pretty precise wiring from the top chamber to the bottom chamber, and there are wires that are in the heart. And that's meant to, you need a normal electrical system in order to have normal pumping of the heart. Okay, so if someone's electrical system is abnormal, then the pumping is abnormal. If the pumping is, blood pressure can drop. So the question that's being asked about the ectopic beats, what that means is that there are beats that are coming from outside the normal electrical system. They're coming from somewhere else.
Right.
Beats are just infrequent every now and then those are usually not a cause of syncope. But if those beats, if there's a focus that's outside the normal electrical system and it beats very fast and it beats for 1 or 2 minutes, then that can end up causing a loss of consciousness. So individual skip beats or ectopic beats are usually not a cause of syncope, or usually not dangerous. But if they come a lot in a row for a minute or two, they can cause loss of consciousness. And the only way to make that diagnosis is to have a heart monitor on at the time the ectopic beats are occurring.
All right. Some of the questions that normally, like people will ask, are they able to do the physical activities or can they drive when they have this type of a disease? Is it, what would you say?
So I would say that in regards to physical activity, it really depends on what your diagnosis is. Okay, I hope I stressed to you that if someone has syncope or loss of consciousness, it could be a non-dangerous problem or it could be a dangerous problem. And so we have to figure out, make a diagnosis first. If we figure out it's a non-dangerous problem, then people can go about their normal activities and they can bike and they can hike and they can run, they can do whatever they want. But if it ends up being a dangerous problem, then we might have to limit them in their activities. Our goal is always to get people back up to full activity and more, whatever they want to do, but we want to do that in a safe fashion. And so in order to do it in a safe fashion, we have to make a diagnosis and then give appropriate treatment. And then we can make a decision how active the person can be. Okay, but our goal is always to try to make the person as active as they can be. In regards to driving, that's the most difficult thing that I do is ask people not to drive. They don't like me after I ask people not to drive because, at least in America, it's a lot
It's a
of
must. Yeah, it's a
necessary to
must. Yeah,
drive.
yeah, yeah.
But the Department of Transportation in several states, if we report the patient and we have an ethical responsibility to report the patient if they are not agreeing to our contract. So a lot of patients, if they have loss of consciousness without any warning, you could imagine if they're going down the highway 70 miles an hour driving and they get no warning and loss of consciousness, they're going to hurt themselves and hurt a
There's,
or maybe run into a school bus, etc. And so I usually try to form a contract with my patients and say, you passed out without any warning. We need to find the diagnosis. We need to treat you. And we need to wait a few months to see whether that treatment's working before you go back to driving. Now, if people have a lot of warning before they pass out, if they say, well, I know when I pass out, I get 3 minutes of warning, I get nauseated, I get sweaty, and I don't think it's a dangerous type of problem. Or if it only occurs when someone's standing, if they've never had it when they're sitting, they're driving, and so I have less of a limitation on that. So it's really on a case by case basis.
oh, okay. That's a good idea, tips we got. Yeah, it's good.
Yeah.
How about, is it heredity? Like, does it pass from parents to the kids and from the,
Yeah, it's not very common hereditary, but this is, the question about whether you have family members that have passed out or that have died at a young age. You have to ask that question to anyone that has loss of consciousness, because that's the only way you're going to end up finding out whether someone has a hereditary component. Now, the EKG oftentimes, not often, but sometimes is a tip-off for a hereditary kind of problem, because we can see some EKG abnormalities we know run in families. So, for instance, if I have someone that loses consciousness and they have an abnormal EKG, and I think that it might be a hereditary problem, then I have to let that patient know that, hey, I think that you need to get a genetic test done through your blood,
right?
genetic test. And then if that's positive, then we're going to have to evaluate all of your relatives, your brothers, your sisters, your kids, etc.
Okay. What about the treatment options? Are they expensive? Are they covered by Medicare, or would you give some light on that?
Yeah, treatment options, as I said, could be very inexpensive, which is salt water, increased salt in water, to they could be from an implantable defibrillator or catheter ablation, which typically run $40,000 or $50,000. So most of all of these things are covered under insurance, and we, before we do any kind of expensive sort of evaluation or procedure like that, we always get pre-authorization from the insurance companies. And I rarely have any problems getting patients covered from an insurance standpoint.
Okay, thank you. Now, suppose if someone has, and how do we take care of ourselves? Is there any lifestyle changes that we can do, or any food intake that we should do, or something that
Well, I
can
mean,
help us? Uh-huh.
yeah, I think that as I told you, that 95% of syncopal spells occur because of abnormalities in the cardiovascular system.
Mm-hmm.
And so I'm a subspecialist of the heart. I'm a heart rhythm specialist,
Mm-hmm.
but my general cardiology colleagues are the general cardiologists who check blood pressure, who check cholesterol, who try to keep you from having high blood pressure and diabetes and high cholesterol and heart attacks and heart failure. So whatever you would do from a health standpoint is going to potentially help you avoid syncopal spells. So, if you take care of yourself with good sleep, diet, exercise, um, in the long run, that's going to minimize the chance of you having heart failure or heart attacks. The less chance that you have heart failure and heart attacks, the less chance you're going to have any dangerous rhythms or blood pressure problems that are going to cause syncope.
Mm-hmm. Okay, thank you. I think we had a very good session, very informative, and I think a lot of people might have enjoyed and got a lot of information, because sometimes when we think about it, like, in fainting,
Yeah,
people usually say, oh, it's fainting only. This is
yeah,
not as simple as fainting. This is more than that,
yeah.
right? Yeah.
Well, I mean, fainting is the simple faint,
Mm-hmm.
one of the causes of syncope.
All
And
right.
that could be, but the problem is when someone faints, as a layperson, you don't know whether that was a benign, a non-dangerous problem or a dangerous problem. So,
Right.
all fainting needs to be taken seriously, especially when people get older and they start fainting. That really needs to be evaluated.
Okay, thank you, doctor. Now,
Okay.
yeah, I think we have almost made it to 8 past 9, so I guess we can close, because we'll have other sessions going on. So thank you very much, and
Thank you.
I would like to also, thank our to tell everyone that we have been having Ram Katha Rahasya going on right now live. So join that, and then we got our Swamiji has been releasing 21 days of mind management challenge videos, and I think today will be the day 7. So keep on watching that and comment and share them. Yeah, it's very interesting. It's about change your mind and change your world. So very interesting topic. And I would also like to thank you, Dr. Manish Asarji and Dr. Kandalwalji, for an excellent webinar. Thank you very much. Thank you
Thank
very
you
much.
for the invitation.
Thank you.
Have
Thank
a good night.
you. You too. You too.
Bye bye.